Welcome to this explainer. Okay, today we are putting on our medical detective hats. We're looking at a fascinating and honestly a highly practical algorithmic framework used to crack the case of chronic abdominal pain. Differentiating between functional pain, like irritable bowel syndrome, and organic disease can be super tricky, right? But it is absolutely essential for patient care. We're going to use this structured approach to follow the clues, decode the symptoms, and confidently arrive at the exact right diagnosis. So let's dive right into this. The absolute core mantra for our investigation is simply this: adopt a positive, symptom-based diagnostic approach, not exclusion-based. For literally decades, medical professionals treated conditions like IBS as a diagnosis of exclusion. You know what I mean? Running endless, expensive, and stressful tests just to rule out everything else first. Well, what's really game-changing about this updated algorithm is that it demands a massive shift. Instead of just ruling out suspects, we are now looking to confidently rule in a functional disorder based on very specific positive symptoms. Take a look at this. This right here is our master investigative blueprint. It maps out the entire diagnostic journey, moving systematically from that initial clinical assessment all the way through to positive diagnosis and management. We're going to break down this whole pathway step by step so you can apply it seamlessly in your own practice. To keep us perfectly oriented, here are the 6 key phases of our clinical investigation, taking us from the initial assessment all the way to avoiding common diagnostic pitfalls. Let's get right to it. Phase 1, the initial clinical assessment. Think of this as gathering our very first clues at the scene of the crime. But before we investigate, we've got to define our parameters. Chronic abdominal pain is officially defined as pain or discomfort in the abdomen that has been present for 3 months or longer. 3 months. When a patient hits that mark, boom, our algorithm triggers. We immediately have to start considering whether the primary suspect is an organic disease, a functional GI disorder like IBS, or maybe something else entirely. During this initial assessment, we are hunting for essential clues. You need to ask very specific symptom questions. For instance, does the pain improve or worsen with defecation? Does the pain correlate temporally with constipation or diarrhea? Is there any bloating present? These are the hallmark signs that point heavily toward a functional diagnosis. We also need to assess their stool pattern using the Bristol stool chart, classifying it from types 1 to 7. This basically sets the entire stage for the rest of our workup. Phase 2, spotting the alarm features. This is where we look for the red flags, and honestly, the stakes get significantly higher here. You absolutely must screen for these do not miss alarm features. We are talking about gastrointestinal bleeding, unintentional weight loss, fever, or nocturnal diarrhea that actually wakes the patient up out of a dead sleep. Also look for symptom onset at an age greater than 50, a family history of colorectal cancer or inflammatory bowel disease, anemia on their tests, or elevated inflammatory markers. Here's the rule. If any single one of these alarm features is present, our investigation immediately pivots. We completely exit the functional pathway and proceed directly to a full organic disease workup, which, of course, typically includes a colonoscopy. Phase 3, baseline laboratory investigations. Now, if there are no alarm features, welcome to the forensic lab portion of our investigation. According to the algorithm, there are mandatory tests required for all patients who do not have alarm features. These are a full blood count, an inflammatory marker check using CRP or ESR, and celiac serology, specifically TTG antibodies. And step 4 is absolutely vital, a fecal calprotectin test. However, you gotta note that this specific test is indicated specifically for patients presenting with diarrhea who are under 45 years old. I want you to notice the critical threshold highlighted here, 250 micrograms per gram. If a patient's fecal calprotectin levels hit or exceed this mark, there's a super high suspicion for inflammatory bowel disease, and we proceed directly to a colonoscopy. Conversely, if the level is under 100, well, that confidently supports a functional diagnosis like IBS. Anything in between is kind of indeterminate and requires retesting to gather more evidence. Phase 4, the decision point. With our lab results in hand, we arrive at the ultimate fork in the road, where our evidence dictates the final pathway. Let's visually contrast these two paths. On the left side, if the patient has alarm features or abnormal baseline tests, we are routed straight to a full organic disease workup. But look at the right side. This is the paradigm shift I was talking about. If the patient has absolutely no alarm features and completely normal baseline tests, we do not keep digging. We stop right there and make a positive, confident diagnosis of IBS. To officially clinch that positive IBS diagnosis, we apply the Rome-4 criteria. The patient must have recurrent abdominal pain at least 1 day a week in the last 3 months. And crucially, this pain has to be associated with at least 2 of the following 3 factors. It must be related to defecation, associated with a change in stool frequency, or associated with a change in stool form. If they hit those criteria, your diagnosis is officially confirmed. Once IBS is confirmed, we got to classify it into one of 4 main subtypes based on their predominant bowel pattern. So we've got IBS-D for diarrhea, IBS-C for constipation, IBS-M for mixed, and IBS-U for unclassified. Classifying this subtype isn't just busy work, it's essential because it directly guides our therapeutic management of the patient moving forward. Phase 5, positive diagnosis and management. The case is cracked, and now it's time to explain our findings and manage the patient's care. Honestly, the most important part of this whole phase is explaining to the patient what functional pain actually is. We have to define IBS clearly as a genuine disorder of gut-brain interaction. It's totally real, and it's vital to set realistic expectations with them. You have to explain that, look, while there is no cure, treatments absolutely can and will improve their quality of life. This requires long-term management and assessing any psychological comorbidities, because the gut and the brain are intimately connected. I want to pause for a second and firmly state the algorithm's rule on endoscopy. There is basically no role for colonoscopy in typical IBS without specific features. You should only perform a colonoscopy if alarm signs are present, if the patient is over 50 years old to screen for colorectal cancer, or if they have IBS-D with atypical features that suggest microscopic colitis. Things like being female, having an existing autoimmune disease, nocturnal diarrhea, a symptom duration of under 12 months, weight loss, or the use of NSAIDs or PPIs. Otherwise, we really must protect our patients from unnecessary invasive tests. Finally, Phase 6, avoiding common diagnostic pitfalls. Because let's face it, even the best medical detectives can fall into traps if they aren't careful. The source material outlines several super common errors. Over-investigating typical IBS with unnecessary colonoscopies wastes precious resources, and honestly, it actually increases patient anxiety. Another big trap is missing the crucial link between abdominal pain and altered bowel habits. Remember, this relationship is the defining feature of IBS. Ignoring psychological factors is a major misstep, as is misusing the fecal calprotectin test in patients older than 45. And the biggest pitfall of the whole bunch, just like we noted at the very start, is continuing to treat IBS merely as a diagnosis of exclusion, rather than actually using positive symptom-based criteria. Which brings us to the end of our explainer, with a provocative question for you to consider. Are you treating IBS as a diagnosis of exclusion, or are you diagnosing it with confidence? By applying this structured, positive algorithm, you can save time, massively reduce patient anxiety, and become a true medical detective in your own practice. Thanks so much for joining me on this deep dive, and keep asking those brilliant questions.